Okay, so we got our usual crowd here. Okay, so let's get started. So if you haven't seen me or met me before, I usually do a lot of these Northern Health outreach to a Chetwynd and a Tumbler Ridge, and also a Shell allows me to do these lecture series. So I've done things like geriatric topics, Parkinson's disease, falls, and dementia, delirium, that kind of the usual suspects. And I'm trying to make this as practical as possible. These are not meant to be these like academic rounds, like we have to present a lot of papers and, we do critical appraisals and things. It's just meant to be very much of a practical thing. So in order to make this as practical as possible, I need some support from you. So you have to ask some questions. You have to get participate. There's a lot of brainstorming involved, and a lot of the times it's a discussion rather than just one-way lecture where I'm just imparting my great wisdom to you. It's actually teamwork. So in order to make this work, please feel free to use a chat room or just ask questions if that's easier. Okay. But we must work together, because otherwise the didactic lecture style, your retention of knowledge is usually less than 10%. So it's not very useful to me if I walk away and then you walk away, learn really not much. So let me keep this as practical as possible with you. I don't have any disclaimers. I don't get paid by any of the companies, especially some of the demonstrations are really just to show you, or demonstration purposes for examples. I don't get paid by any of the companies. And I'll try to keep this very simple. I want you to walk away from today's session thinking that, okay, so insomnia. So what about insomnia? Why is it bad for you? Okay, what can I do for these patients with insomnia? Okay, is there some kind of therapy available? And what's good about it? What's bad about it? Okay, and hopefully try to keep this as realistic as possible, because I'm not going to be prescribing some fancy medication that's only delivered in a certain academic center, and it doesn't really work for people. So it has to be practical to you, something that you could prescribe, something you can use on your own. So let's quickly walk through the sleep, and this will become more important later when we discuss why certain things are so or isn't. The sleep comes in stages, so you're probably familiar with it. There are different stages where a sleep is you're sleeping but not really helping you restore. It's not really helping you feel better. It doesn't really serve a whole lot of a function. So that'll be stage 1. So this is kind of like a transition stage, if you think about it. So when you're falling asleep in the middle of a lecture, that's a stage 1, because you still want to be awake and be ready to pretend you weren't sleeping, right? So stage 2, it's majority of your time, and it's somewhat helpful, but it's really not the kind of sleep you want to be doing, because it doesn't have the benefit like the stage in 3 and 4. This is where we have the slow wave, and this is the one that gives you I feel refreshed, I feel better, okay? And this is where we have the immune functions, restorative functions, and also the growth hormone release, and all the good stuff happens in stage 3 and 4. Unfortunately, we don't get to spend as much time in this stage, and if you were to work on insomnia, we should be really working on improving stage 3 and 4 rather than stage 2. And about the rapid eye movement, right? The REM, this is when you have literally the rapid eye movement in your sleep. And this is an indication that we're actually dreaming at this stage. The rest of your body is paralyzed, but your eyes are not. So you're acting out your dreams. Okay, and when the rest of your body is not paralyzed, this is when you have parasomnia, right? Some funny things happen. You're sleep talking, thrashing about, or even worse, sleepwalking. Entirely different pathology, but quite interesting. Okay, so keep this in mind. It will become somewhat useful later, why certain medications are helpful and certain ones aren't. So we go through a cycle in our sleep. So it's not that we're just sleeping in one stage forever. We go into deep sleep, light sleep, and we're going in a cycle like this. And depending on, have you ever had an experience when you got woken up suddenly? Okay, be it your children, or be an earthquake, or some kind of a shock to your system that woke you up. Depending on where in your stage, you could react really differently. So some funny things happen when you get woken up in the middle of REM sleep. and you can be quite confused and dazed if they got woken up in stage 3 or 4. Okay, have you ever had that? It takes you a while to figure out what the heck is going on. Yeah, so that's a stage in 3 and 4 sleep. So you should be really pissed off when this happens because you just lost a valuable sleep, which is only 25% of your sleep time. So you should be more mad, as opposed to stage 1 sleep. You get woken up, you know immediately what's happening. Okay, so this is when I call you out with your videos on, your eyes are falling asleep, and I call you out, you pretend nothing happened. So that's stage 1 sleep. So you didn't lose much. Okay, now the sleep itself, we don't fully understand the entire function of the sleep. We seem to be sleeping about a third of our lives away, and young adults, 33%. Kids, a little bit more. So 2/3 of their lives are basically sleep. So it must have some kind of function. And older adults, this is normal variation where they tend to sleep a little bit less, they're a little bit more awake, and then they have less of that valuable stage 3 and 4 REM sleep. They have more of a less valuable, less intense sleep, stage 1 and 2. Now, it's a tendency. It's a part of normal aging, but you know what isn't normal is insomnia. It's common disorder, but that doesn't make it normal. I want you to understand that difference, okay? Just because something is common doesn't make that normal. Just like dementia, you have dementia in an elderly, more common, doesn't make that normal. It's just a common disorder, that's all. Okay, and the sleep is, there's a lot of interesting data comes out. For example, if you have more REM sleep, you tend to have better memory, and if you're more sleeping more with medications that reduces REM sleep, your recollection and the test scores actually seem to be worse. So it seems like these different stages of sleep serve different function. And this is exactly why people say you shouldn't cram for your exam the night before, because you actually have a better chance of regurgitating information if you had a better night's sleep with better REM than, try to cram in that information. Unless you've studied nothing and you're really banking on that one-nighter, then it's a different story, but hopefully it's not the case. I just want to show you this graph. I just think it's really interesting. If you look at the babies, okay, the total amount of sleep, it's like 15 hours. Okay, and of course this is broken up into, those of you who had children would probably know that they're not 14 hours straight sleep and they're awake for the 10 hours. That would be fantastic, right? But life doesn't work like that. It's also interesting to look at it right in the middle of the graph. You see that 29 to 30 and so on. Your average sleep kind of tails off there. So your total number of hours sleep is about 8 hours. Okay, 8 to 7 hours seems like. This is the average. And of course, most of us are laughing at this because the scientists think we sleep 8 hours a day. Right. Mind you, not everybody has jobs, right? So, okay. Quick question. Is poor sleep bad for you? Yes. Correct. So why is it bad for you? It seems that poor sleep has impact on many different areas. So biologically, so is it bad for your body? Yes. It seems like the immune system seems to be affected if you have poor sleep. I mean, most of you have noticed it, right? If you had a really busy week, not sleeping well, sometimes you catch a cold. Okay, it's not that you catch a cold when you're tired. It's just that your immune system seems to be less functioning. This is like a common knowledge. Hypertension, cardiac outcome. So if you have insomnia, it tends to increase your blood pressure, and actually it has impact on your cardiac outcomes. So I mean, you probably more stressed too if you have insomnia. So there's many other factors. So this is not like a causation, but there seems to be a pretty strong correlation. You just don't feel good. So that's a functional impairment. So it's more than just your body, your mind, your day-to-day function. So having poor sleep increases risk of your accidents. You just don't feel good. You just don't feel like doing things. So productivity goes down, absenteeism goes down, and this should be pretty obvious to you, right? If you don't sleep, you don't feel good. That's like a common knowledge. We all been there. But if you can't sleep for a long enough time, this could actually frankly lead to depression, anxiety, okay? And a lot of times substance dependence, for example, things like alcohol, very common, okay? A lot of people self-medicate to go to sleep with alcohol. And then insomnia kind of goes away. They're just drinking now. So it could be a risk factor. And you can also increase the risk of suicide. I mean, none of these should be new information for you, right? Bad sleep is bad for you. So when somebody has insomnia and they come to a healthcare professional, you should have some kind of a big picture plan. Okay, so what do we do with this information? They tell me they can't sleep. So the first thing we should identify is this a problem? Okay, if they say the intensity of the insomnia is such that they're only barely sleeping a couple hours a day, and this is causing some physical symptoms the next day. I can't seem to function, and I'm a truck driver. Now you can see that this is actually a problem that needs to be addressed, as opposed to some people who subjectively say, you know, I can't seem to get the same quality of sleep as before, but you know, I seem to function fine and I'm not really affected by this. Doesn't bother my job. You know, this is not affecting my quality of life. Get a sense of the problem. How problematic is this? Okay, and the way you do it, we'll talk about this in diagnostic measures and objective measures. And the next thing we should do is that, okay, so you can't sleep and now identified that it's a problem for you. Is there something that's causing this? Yeah, I haven't been able to sleep since I bought this new TV. Okay, and they installed it in their bedroom and they're watching TV. So something very specific, then you can remove that TV from the bedroom. Good luck. But if you were to do that, maybe the problem goes away. So very oftentimes there's a specific cause why you can't sleep. There's some kind of a problem that you're anxious over, or you just started a new medication. Maybe there is some kind of a medical problem. I can't seem to breathe at nighttime. My legs are swelling up. Okay, I'm coughing. I'm short of breath, and that's why I can't sleep. So the second thing is identifying the cause, a reversible cause. And then number three, depending on the severity and urgency, that will require medications or not. We're going to get into more details of that. Okay. And number four, so this is what I want to talk to you about a little bit more today, is a patient, first of all, willing to work for it? And two, are they capable of working with the cognitive therapy? Because we're all looking for a quick fix. I can't sleep. Here's a pill. Take this pill, and then your sleep problem will go away. They're looking for a quick fix. And in reality there is no such thing. So as I present my data with you, you recognize that the drugs are not the answers. And number five is, if you have to use the drugs, okay, there's some clearly role for pharmacological therapy. Can they tolerate it? Okay, what are the risk factors? So we're going to go through this together. Okay. So let's make the proper diagnosis first. And taking the time to take a history is crucial. And we've really got to figure out, is there something that's triggering this? If you get this early on, you might be able to actually reverse the whole process before they become a chronic insomnia, more than 3 months, and then it becomes a lot more difficult because you can get something called a conditioning, sleep conditioning. And that's a behavioral issue that we need to fix, and it takes a longer period of time. And it's really nice to have a sleep partner available, because I don't know if you noticed, but when you're sleeping, you don't remember much. Okay, so you got to do a full medication history that's including over-the-counter stuff, substances, okay, oftentimes coffee, tea. A lot of people don't realize how much caffeine is in their tea. So in order to make the proper diagnosis, you have to use some kind of an objective sleep measures, okay? You can use the sleep diaries, insomnia severity index, Epworth sleepiness scale, which is not so much for insomnia, but we use it for, you know, the OSA, right? So for example, this is just an example of a sleep diary. So you can just ask your patients and clients to just Google sleep diary. Okay, this is really not a rocket science, right? So you want to just organize the day, Okay, what time you went to bed, what time you got up. If you got up, woken up in the middle of the night, record that. Okay, and you can kind of figure out, was there a trigger or something that you want to take a note on? Okay, I drink coffee at 10 p.m. Then you can say, why the heck would you do that? Give them hell for it, but you can identify the cause. Or my child jumped on me at 3 a.m. last night. Okay, get rid of the child. Simple fixes. Or lock the door. Well, not on the child. That'll be abuse. On your bedroom. Oh, geez, people. So sensitive. So when you continue your interview, the sleep diary really is useful because you can figure out their usual pattern, and then very quickly you will find out that a lot of times the issue is that there is no pattern, and in fact that is a problem that we can work on. And then you can figure out how much time they're spending in their bed and how much of that is actually sleeping. What I'm trying to get at is the concept called sleep efficiency, because the spending time in bed doesn't actually mean anything. What we really care about is how much of that are you sleeping. And in fact, if you're not having a good sleep efficiency, that's again a problem that we can address. Okay, so ask questions, simple questions like, do you take any medications, or do you take any medications to stay awake or stay asleep? Do you drink any alcohol? Do you drink any water? Do you drink any tea? Just get a full history of ingestion just before they're asleep. Because a lot of times you notice men, their common problem is bathroom, right? Oh yeah, and the last question, what else do you do in the bedroom? So it's not meant to be a funny question. There is a concept of a conditioning. So what do I associate the bed, the physical space of bedroom or the bed with? So we should really limit your bedroom to either sleeping or having sexual activities, because if you use your bedroom, some of you eat breakfast in bed, some of you watch TV in bed, or do work or what have you in bed, then you start to condition your brain away from the specific activity of sleeping, because we're creatures of habit. And then you might want to get some information on maybe other sleep disorders I talked about, some really interesting stuff like sleep talking, okay, not so interesting after a few nights, snoring, choking, or frankly, they're getting up to do tasks. So that'll be the sleepwalking, right? They can be quite complex. I actually had a patient who would get up in the middle of the night and sold his stocks and got really upset. And this was actually very complex. Just to give you an idea of how complex these movements can be, they can be fully cognitive when they're sleepwalking. And the restless leg syndrome, and so periodic limb movements, and things like this can happen. Okay, because these require entirely different set of therapies. Okay, now spend a little bit of time explaining the environment of the bedroom. Is there noise? Is there light? Okay, is there TV? Is there animals? Is there children? Okay, things like this. The temperature. It's common complaints. Some say it's too cold. The other person says it's too hot. And accusing each other of stealing the blankets. Bed's too hard, it's too soft. So those are the common complaints. Okay, you can add up. A small amount of these complaints can add up. Okay. So we've identified now this person has an insomnia. And we identified that this person's insomnia is severe enough that it's bothering them. And you decided that the treatment needs to start. Okay, so then we have some treatment options here. Now, before we go into the options, any questions about the diagnosis so far? Okay, so far pretty clear. And as you can see, this takes a long time. And so the sleep insomnia, the interview could take a long period of time. And one way to save some time for you is actually, before they come in, you can ask them to to fill out a sleep survey or sleep hygiene survey, and you can just ask them to Google something online, okay, so that they can fill out all this information about their sleep patterns and some of the sleep diaries and things like this, okay, and that could save you a lot of time. And in your practice, if you're a family physician, they can mention a sleep insomnia, okay. You can briefly screen how severe this is and send them away with some information for them to gather, and then come back and do a proper interview next time. Okay, so these informations are all non-proprietary, and not that you really need any proprietary information. Just Google something, some kind of interview sheet, and sometimes your office may even have them pre-printed. Okay, and this way you can save a lot of your face-to-face time and defer the data gathering to the patients on their own free time. Okay, so let's talk about therapies. So there's drugs and there's non-drugs therapy. And as a geriatrician, I always prefer the non-drug therapies, but there are certain benefits of the drugs. So let's go over some of them and let's see if I can debunk some of the common misconceptions. Oh, let me see. Okay, so why do we prescribe sleeping pills? It's very common, and in fact, more than 10-20% of the elderly start using sleeping pills of some form because insomnia is very, very common. And you know what we're looking for here is actually a quick fix. We just think that we can prescribe a drug and then maybe they will sleep better, and then the problem will go away, and therefore problem is fixed. And it's that idea that's that we need to demystify, because that's not actually what happens. Because the chronic insomnia that we often deal with is not something that we can fix with the drugs alone, because the drug sedatives only work for a short period of time, and they can become quite dependent, and it loses the effectiveness. So really up to a couple of weeks. Okay, so transient situation, you're jet lagged, or you're shift worker, or some kind of a specific situation where you can't seem to sleep. You're going through, there's a construction nearby or what have you, right? So circumstances doesn't allow for you better sleep, then might be a good use. Or maybe you're using the real therapy, the non-pharmacological therapy, and you need something to help you boost it, okay? It's a secondary therapy, because a lot of side effects can happen if you use one of these drugs for a long period of time. So if you have to use it, there are certain circumstances that I mentioned. There are situations we need to have sedatives. Then try to use as little as possible, okay? Because you can always take another dose, but you can't take away the dose you've already taken, and then you are experiencing the side effect the next day. Use a shortest duration as necessary. Really, 2 weeks will be the cutoff. I wouldn't prescribe more than 2 weeks at a time. Okay, and if they need a refill, they need to reassess why isn't it working. Okay, and then you don't want the rebound, so taper them off. Okay, half a tablet of whatever you're prescribing, start half the dose and go on a full dose and go back to half a dose, and so on. Okay, that's including over the counter. That's including herbal medications. Okay, whatever you decide to start with. But really, the money is at the bottom, the CBTI, the cognitive behavioral therapy for insomnia. So that's where I want to spend a lot of my time with today. So what are the options? So the common ones, benzodiazepines, right? Ativan, we got diazepam, okay, alprazolam, these medications. And non-benzos, what do we got? Zopiclones, right? Everyone's quite familiar with it. And melatonin, or in America, they got the melatonin receptor agonist, which is pretty cool. They've got a ton of data. We don't have it here. But melatonin is a reasonable substitute for this. Some antidepressants, you know, like trazodone, commonly known, right? Mirtazapine, okay? And tricyclics, amitriptyline, nortriptyline, okay? Doxepin. Antipsychotics. Quetiapine is a quite common one that we use as an off-label. Antihistamines, for example, the sleep aid, right? That's a diphenhydramine. So that's first generation antihistamines, and gravel, dimenhydrinate. So we got lots of drugs, and they've all got their problems. So side effects. What are the side effects? I mean, you're giving them sedatives, so what do you expect? Drowsiness, right? Um, the problem with the benzos is this. What we're doing is actually the pharmacology of these drugs are very similar to alcohol. So imagine when you're drunk. Anybody here had any alcohol? Like ever? So remember how that feels? Well, some of you don't, then maybe you should cut down. The impact, just imagine the impact of drinking, except the half-life is multitudes longer. So you may not think you're drunk, like a lot of people say, I'm not drunk, but you look at them clearly intoxicated. Exactly same thing happens to you during the daytime. So the daytime somnolence, and it may not be as much as a feeling tired, but feeling groggy, reaction time, and your gait, your memory, your executive function, your ability to handle multiple tasks, all those things can be impacted. And there's a tolerance, there's a dependence, there's a withdrawal. It basically is just like alcohol. Now, the reason I want to talk to you about the benzodiazepines, because of the side effect, especially in elderly, there is increase in hip fracture, increase in falls, increase in trauma, increase in cognitive impairment, okay? All sorts of things go up. So we don't use benzodiazepines in elderly, right? This should be a fairly well-known information for you by this time. Now, the other thing is a zolpiclone. We tend to think zolpiclone to be a safer alternative to benzodiazepines we just talked about, right? So it should be common knowledge for you to think that benzodiazepines are bad for you because they're just like alcohol. And is zolpiclone safer? I give you a hint, it's on the slide. No, it turns out it wasn't. So there are definitely benefits to zolpiclone. It's less dependence forming, less habit forming, and withdrawal impact is much lower. And they seem to have much less of the cognitive impact. But it turns out when we compare the Z drugs, so including zolpiclone, so in America they got zolpidem and a couple of zolepilone, a couple of other options. So the Z drugs is a category as opposed to benzodiazepines as a category. We looked at it in a large systematic review. Turns out they weren't any safer. So it's kind of a bummer. There are increase in risk of falls, increase in risk of fracture and injuries, very similar to benzodiazepines. So these numbers, the odd ratio, you're 2.4 times more likely to fall than somebody who's not taking them. It's actually quite similar within statistically an insignificant range. They're pretty much the same, meaning they're just as bad. So it's a bit of a bummer because we're using zolpiclones a lot lately in replacement for benzodiazepines for the purpose of insomnia treatment. So really we should rethink giving out the zolpiclone. Okay? Well, some people really like these medications, benzos and zolpiclones. Okay? And here's something for you to think about. Okay, why do we prescribe sedatives? Why should we treat insomnia? So we talked about the impact on our biological and psychological and the functional component, right? Now, when somebody complains to you about poor sleep, it's not the poor sleep they're complaining to you about. It's actually how you feel the next day. That's the real question we should be asking. How is their function? So let me ask you, if you sleep, say, 6 hours a day, okay, and you had a poor sleep, you only slept for 4 hours, is that a problem for you? It really depends on how you feel the next day. What if I told you you slept for 4 hours and the next day you just feel like just done. You just feel like you got hit by a truck. You just can't seem to do anything. Is that a problem? Yeah. But what if I told you then You slept for 4 hours, but the next day you feel great. I feel fine and has no impact on my life whatsoever. Amazing, right? The point I'm trying to get across to you is that we shouldn't be just looking at the sleep. We should also be looking at how you feel the next day. Does everybody agree so far? You follow me? So then, what if I gave you a drug that makes you sleep for those 6 or 7 hours instead of the 4 hours because your life is now miserable? And now I've given you this drug and now you're able to sleep 7 hours. Okay? Does that sound all right? So what if I told you that you slept for 7 hours instead of the 4 hours you've been suffering from, but you still feel groggy, you still feel tired, and you still feel slow and sluggish, but you slept 7 hours? What do you think about that? So there's a study looking at the Z drugs and the benzos, and I can tell you that they work. So their sleep hours, total hours sleep goes up. They sleep more. Sleep latency falls, meaning they fall asleep faster. Okay. Awakening interruptions are reduced, so you sleep less interrupted. And your total sleep efficiency is better, so you sleep more in less amount of time. It sounds really good, right? All these drugs have strong track records for this. Okay, they work. But what they also have reported is that the next day function, next day feeling refreshness, the subjective feeling of the patients taking these medications, the score is actually not different from placebo. What does that mean for you? That means you sleep better, but you don't necessarily feel better the next day. So you really have to ask this question, what is the point of all this? Right? So this is a big marketing thing, right? Because when they're marketing these medications, it's quite simple. You have trouble sleeping, here are the drugs that help you sleep. And do they work? Absolutely. Here's the data, and they're fantastic. Okay. What they don't tell you is that yeah, you sleep more, but you're not going to feel any better. So that's the problem. Do you see the problem here so far? This is why I'm really trying to steer everybody away from prescribing sedatives just so that we can improve the numbers. Okay, so they sleep better, sleep more hours, more efficiency. Okay, and they serve a very specific function, which we'll talk about. Okay. So medications like tricyclic antidepressants, the old school drugs, amitriptyline, doxepin, things like this, I really don't see a role in these medications in sleep insomnia. So in fact, if you see a patient taking amitriptyline, doxepin, nortriptyline for sleep only, I mean, not for depression. If they're on depression, I mean, really, they should be considering changing to another medication or say chronic pain or what have you. You can review it, but as an insomnia, as a primary indication, they shouldn't be. As simple as that. Okay. Now this is 2020, 21st century. These drugs are made more than 70 years ago. We should not use these medications anymore. Trazodone. This is an interesting one. So if you're familiar with the trazodone, it's an antidepressant, and one of their major side effects was drowsiness, and we're capitalizing on that to use trazodone to help insomnia. Does it work? So the data for trazodone, it's actually excellent if you have depression, and insomnia is one of the symptoms of depression. It works in a fantastic way. Okay. So depression with insomnia features, trazodone is an excellent choice. However, people without depression and they're using trazodone as a primary indication for insomnia, the data is very fuzzy. Okay, so in that case, I wouldn't support use for it. I would use trazodone in a short term in off-label fashion for people who are absolutely struggling because it has the least amount of impact on their REM sleep and sleep stages. So remember we talked about sleep stages? Okay, benzodiazepines and the zopiclones put you in a sleep stage 1 and 2 faster and spend more time there. So you're sleeping longer, but you're not recovering as much. This is why they feel kind of crummy the next day still. As opposed to trazodone seems to have more impact on a stage 3 and 4. And we think it's because there's some degree of the depression which destroys that deep sleep stages. And trazodone and the antidepressants actually treat the underlying problem. And we think that's why they work so well. Okay, again, I don't encourage using this as a primary indication for insomnia, but you should really screen for depression. That's quite common. And same thing with the mirtazapine, very, very similar. They're slightly different mechanism of action, but who cares? The bottom line is that it's got a side effect, make you drowsy. And this drowsiness, especially if it's associated with a depression, it's a fantastic drug. Antipsychotics, for example, quetiapine, Seroquel, right? A lot of times we use it for insomnia, especially in elderly and agitations. This is off-label use, and it's medical legally speaking, it's quite dangerous. If something happens to patients with quetiapine as a result of the quetiapine, it would be difficult to defend yourself because it's not indicated. And I can tell you the side effect profiles of the antipsychotics are horrific. I don't know, some of you listened to my previous talk on dementia delirium. You remember about the mortality rate? They are horrendously bad. So increase in risk of stroke, heart attacks, false fractures, hip fracture, and aspirations. These are horrific drugs. And the only reason we use them is because they work very well for things like psychosis, because they're antipsychotics, right? So if there are symptoms that needs to be treated and the benefit outweighs the risk, then we will use them. And a lot of times these patients, their benefits outweigh the risk because there's so much harm of not treating their underlying condition. When it comes to insomnia, I cannot justify using these medications. Therefore, I don't recommend it, and we shouldn't be using them. Although, if insomnia is one of the symptoms of their behavioral issues or psychotic issues, in that case, you can use it as a second benefit. Okay, and that's primarily what I use it for. If you're going to use it, baby dose. Quetiapine will be something like 6.25, 12.5 milligrams. These are not your depression patients with the augmentation where you use 150 milligrams, right? So make sure you use a smaller dose in elderly. Yes, so I mentioned lots of side effects, and the list, it's not only the long list, it's actually how common that is. A mortality rate, the number needed to harm is one in between 20 to 30. So let's say 1 in 25 people will die as a result of these drugs. Does that sound pretty bad to you? 1 in 25 people dying as a result of prescription of this? I would say so, especially when it's off-label, so not indicated. So really, I want you to, those prescribers in the crowd, please think about this, okay? It'd be very difficult to defend yourself in court if something happens to your patients and we're using for insomnia. Yeah, so the risk of serotonin syndrome with the trazodone and SSRI, yes, it's real. However, remember the dose we're using for these patients are really small. So compared to, say, trazodone in depression dose, 100 milligrams, I'm using 12.5, 25 milligrams. So relatively speaking, it's a single agent trazodone as serotonin syndrome is very, very small. Now, serotonin syndrome usually happens when you mix medications, something with another serotonin release. Okay, and it's a real problem even in the lower doses if you're mixing medications because the effect can be amplified. So certainly you want to use a pharmacy as a good resource for that. Now let's talk about melatonin. So melatonin is our natural hormone that you produce, right? And then you produce it towards the evening throughout the night. And it's a very little side effect associated with it. Maybe a slight hypertension noted in some studies. Daytime somnolence is not very much. And we know that the levels of melatonin is reduced in elderly in their physiological state. So it makes sense to replace it. And basically the bottom line is this. Is it safe? Yes, it seems pretty safe. Does it work? The studies are, it's not something I'm gonna get excited about. What I can tell you is that I might have a slide here. Okay, so it's a busy table in the graph, but basically the bottom line here is that it seems to work, but it's not overwhelming. So if the graph is on the right side of the center, it works. If it's on the left side of the center, it doesn't work. That's what all the results of different trials are trying to show you. Seems like most things are skewed to the right, so there's a signal that it's probably better than nothing. But you know, I'm not too crazy about it. But hey, there's very little side effect, and these things cost pennies, okay? And they're much safer. I would use them, yes. I would recommend melatonin regularly. Now, when it comes to insomnia, when it comes to anything that has to do with symptoms, the placebo effect is huge. If I prescribe a Tic Tac to patients as a powerful sedative, they sleep better. And in fact, there's placebo studies just to prove that point. And this is why we always do trial against placebo, right? So placebo effect is quite big. And now melatonin is slightly better than placebo, it seems like. So in real life, actually they work pretty well. Okay, so don't be too discouraged by the trials, because what it matters is practically what happens in real life. Okay, if I gave you a painkiller, actually this really happens. It's a strong painkiller, so I can only give you a little bit at a time. The patients have good impact, perceived pain relief. It's amazing. And insomnia is no different. And we'll talk about the cognitive impact on insomnia. So sorry, my slide kind of got cut off there, cognitive therapy. So CBT, cognitive behavioral therapy. Are you familiar with CBT? We use it in anxiety, personality disorders. It's a powerful thing. There's a specific form of CBT, cognitive behavioral therapy, called the CBTI. It's a very it's a colorful name. Insomnia specific CBT. So basically, what is a CBT? So just to explain the CBT in general, it's a cognitive behavioral, meaning you get some kind of a guided education, and then you review your thought process, and then we're trying to alter them. It's not like a mind control, but being mindful. Okay, and there are different components to a CBT. So this isn't just the hippie dupas kind of a feel-good therapy. This is actually well-documented, well-studied therapy, and it works very well because the thing about this is that it really gets to the root problem, which is actually the cognitive construct and conditioning. So what do we got there? The components are the stimulus control, and you got sleep restriction, relaxation, and sleep hygiene, and then cognitive therapy. I will walk through some of these things. Does it work? Absolutely works. And so what I want you to see is that does it improve your sleep efficiency? Okay. So on the far left side, you see the CBT, and then you see the drugs, right? Pharmacotherapy. Okay. It seems to really work. Now, what I want you to look at is this. Look at CBT in the far left. In the middle of the therapy, yeah, it seems to have some benefit. And when you finish it, it gets even better. Now, you look at the drugs. In the middle of the therapy, what's happening? It works. Not as good as a CBT, it works. And then eventually what happens at the end of the therapy? It doesn't work as well. What are we looking at here? What we're looking at is that the drugs have some kind of a dependence or tolerance effect. So eventually drugs stop working. Do you see the problem here? It's a short-term therapy, right? And insomnia, very often, the ones that we're concerned with are chronic conditions, right? So we should really reserve drugs for short-term problems, some kind of a specific circumstance where they can't sleep for short-term. And the benefits of the CBT is that It's a long lasting because I'm getting to the root problem, and there's really very little side effects by going through mindfulness practice. Okay, so let's walk through the process together. Okay, the patients can do it themselves. Okay, there's a lot of online resources, but the best one is if you actually do it through counseling or some kind of online based real-time feedback. Okay, and now it's actually perfect during pandemic because there's a lot of Zoom ones available. A lot of companies offer this. A lot of psychologists offer this. Okay, so you can do this through Zoom. So you're not limited to where you are. As long as they have internet access, as long as they're willing, as long as they're able to. So they got to have some cognitive function, right? If they have significant dementia, this is probably not going to work. Okay, but select your patients wisely, and it's not limited to elderly. This is for everybody. Even some of you may suffer from insomnia. Try this. First, stimulus control. The concept is that we're trying to condition you. So remember we talked about I'm trying to reserve bed for either sexual activity or sleep only. I don't want you to go to bed to work on your project. I don't want you to go to bed to just finish typing off whatever. I don't want you to be looking at your phone or your laptop or TV in the bedroom. I'm trying to establish that conditioning. Remember the good old days when we didn't have smartphones? We only had TV in the living room? Yeah, those were the good old days because you really didn't have this problem of overstimulation in the bedroom. And this includes only go to bed when you're drowsy. And if you're not sleepy, you're just laying in bed, just counting sheep, it's not happening, get out of bed. Okay, it sounds like a bit unorthodox and maybe not, it's quite counterintuitive to some of you, but the concept is this. You are laying there not sleeping anyway. Stop trying so hard to sleep. Okay, if you're not sleeping, you shouldn't be there. Just get out of bed. Okay, and doesn't mean you can get out to the living room and start watching TV. Okay, go to the chair, read a newspaper or something, not on your phone. Okay, I'm trying to get rid of stimulus, right? But come back to bed when you're drowsy. That may mean you may not sleep as much, but your sleep efficiency will improve. Okay, and now we'll get to the next point. Does that make sense so far? Any questions? So the therapy to see CBT, basically zero. There's all 9. So there's a non-therapy based ones. You can go right away. A lot of patients might start with that because it's cheaper. And there's a lot of people, basically all the therapists now are offering Zoom. So you can pretty much get any therapist. There could be one in Arizona. There could be one from, I don't know, Vietnam. It doesn't matter, right? So the therapists are available anywhere. So pretty much you can get in right away. Okay, so do you understand the concept about stimulus control? Should be easy concept to understand, but hard to let go. That's why talking to a human being is a little bit better, especially the part about, when you're not sleeping, get out of bed. That part is kind of difficult. And I'll come back and reinforce that. And everybody's aware of the sleep hygiene, right? The concept is very popular on popular culture, and this is well known. Sleep hygiene is actually only one component of the CBT. Sleep hygiene is, and let's not have dirty sleep, meaning let's not have caffeine in your system. Let's not have too much water on board so that you need to go pee. Okay, these are the factors that dirty your quality sleep. Okay, let's not eat something that's just so acidic that you're going to have heartburn. Let's not exercise regularly just before bed. Okay, let's not have an argument just before bed. Have your argument in the morning. You want to have sheets that's comfortable, okay? You want to have your sheets that doesn't smell, okay? You want to have your bedroom slightly cooler, dark, quiet. These are the sleep hygiene measures. I think everyone's familiar with the hygiene, sleep hygiene. Yeah, it's pretty well-known concept, right? So you should definitely incorporate this into your sleep CBT. Any questions about this? Sleep restriction kind of goes back to that stimulus control. Remember when I was saying that you should really get out of bed when you're not sleeping? Because I don't want you to condition yourself laying in bed and not actively sleeping. And sleep restriction is pretty much how you do it. And I'm trying to induce a mild sleep deprivation so that I'm actually cutting down the amount of time you spend in bed asleep. And you cut it down to just a few hours. And there's a way to calculate this, and there's a tools for that online. And then you're trying to figure out your sleep efficiency. And you want to make your sleep efficiency like 85 to 90%. Okay, so the nitty-gritty details of this, they'll walk you through. Okay, but the concept is that I'm trying to make myself such that like I'm tired and I'm sleepy, ready to go to bed. Okay, and then when you hit the bed, your sleep efficiency is high, meaning you're in bed, you're sleeping. So that's the idea. And this is actually quite difficult, and this probably needs a little bit of help from someone else, okay, because it's a motivation issue. Because what I'm trying to get you to do is, I know you're tired, but get up, get out of bed. Okay, I know you're sleepy, you want to go to bed, don't go to bed yet, don't nap, okay? You go to bed at this time, and then you're going to wake up at this time. It's almost like a boot camp military, right? And the idea is to sleep restrict, so you're in a slight sleep deprivation, and this way you can really condition yourself to sleep. Okay, you can see that it's very similar to like a boot camp situation, right? But this thing really works if you use it wisely, and it's kind of like having a personal trainer. Yeah, so having that clock there, okay. Actually, it's funny because in sleep hygiene, they teach you not to have a clock that's visible and makes noise because you lay there listening to the tick-tock. So relaxation is how you get to sleep. So trying to reduce your sleep latency. So there are many different types. So actual relaxation. So I don't know, has anybody had a massage? Has anybody fallen asleep during massage? So what's going on there? You're trying to relax, right? And massage helps you relax. And see how powerful that is? When you relax, you can fall asleep. Okay, and that's the same concept. Before your sleep time, you're trying to go through muscular or psychological relaxation. So common way, very popular now, right? Meditation. Okay, do it in the morning or do it at nighttime. Okay, and biofeedback. So biofeedback, you probably need someone else to help you through. Just it's a process of mindfulness, right? What are you feeling? Okay, and trying to accentuate and a focus. Okay, imagery, hypnosis. There are other ones that the therapist can help you through. Okay, so the relaxation is a big component of how we're going to do the above. Okay, so this part, it's going to be a little bit more therapy guided. Cognitive restructuring. What am I talking about here is this. Have you ever had an experience where you sing in your car, you sound better? Or you sing in the shower, you sound better? Basically, what I'm getting at is that when it doesn't matter, when no one's listening, you tend to perform better, okay? Meaning that there's a lot of performance anxiety. And then it's like self-imposed. So sleep, especially in a type A personality, sleep is like a competition. I'm going to sleep hard tonight. I'm going to sleep well tonight, okay? And I don't know where we get this misconceptions from. 8 hours of sleep is what I need, and I'm going to get it. That type A personality, that anxiety, causes the performance anxiety, meaning that the more you want something, it's harder to get because you're anxious. Okay, So why is that? It's a sympathetic tone, right? So instead of the parasympathetic, when we relax and when we eat, digest, it's somehow the sleep is turned into this competition. You want to sleep hard. You want to win this sleep medal. And now we got the sleep trackers and all these apps. Let me tell you, this stuff is not helping you because you look at the data the next morning and they say, oh, I'm going to sleep 5% better tomorrow. No. Get away from that idea. So the cognitive restructuring is focusing on that. Let's get rid of that anxiety. Let's get rid of that performance anxiety. Okay? And that means let's get rid of some of the misconceived ideas. Oh, the 8 hours of sleep at nighttime is a common one. Just like 8 glasses of water per day. Where did that come from? It didn't come from doctors, I'll tell you that. There's no physiological studies done on this. And 8 hours of sleep, there's no studies telling you 8 hours is all we need. What we got is that seems to be this societal norm, or it seems to be the normal number of hours people sleep. Okay? And if you sleep less than that, is that a problem? It doesn't necessarily mean that, right? Remember I told you that sleep stages, some people have higher percentage of stage 3 and 4. They have less need for total number of hours sleep. Everyone's different. Some people need 10 hours. Don't be embarrassed or ashamed by it. Okay? Your physiology is such that this optimal hour set for you is different than the societal norm. Okay? This is not a physiological norm. Okay. Oh, you're welcome. So insomnia can, if I don't sleep well today, I'm going to have a terrible day tomorrow. Meaning, oh, I have a terrible day as a result of my poor performance tonight in sleep. Does that make sense? You're building up all these false ideas. And the cognitive restructuring helps you de-process some of these ideas. Okay, and reduce that performance anxiety. Okay, so any questions about this so far? So then what do? Basically, the bottom line is this. I think everybody who is willing and able to participate in CBT should try CBT as their insomnia therapy, chronic insomnia therapy. And what do we do about the drugs? This trazodone, what about this benzos and zolpidem? If you must use it and it's urgent, feel free to use them short term in the beginning, because as you saw from the studies, they seem to lose their effectiveness, but they seem to work faster. So you can start them with these medications and then continue with the CBTI for several weeks for a more long-lasting benefit. Okay? So basically, to summarize, make the good diagnosis, take your time with the history, get them to fill out some sheets and some data, and drugs should be only used in certain cases, and if you must use them, use it as a short term while the CBT really does its job. That's the bottom line. Any questions about this so far? Okay, very good. Well, thank you for staying awake. I lost a lot of the videos, so looks like many of you have fallen asleep right around lunchtime. I think we retained about 50%. That's not bad. It's better than your stage 3 sleep. Okay, have a good night tonight. I'll see you next time.
Thank you, Dr. Lee.